everyone. My name is Natalie Morgan, and I am the Oncology Pharmacy Resident here at Monument Health Cancer Care Institute. And for my clinical pearl this month, I am looking at same-day versus next-day administration of pegfilgrastim in patients with breast cancer. My objectives are to present the findings of a retrospective multi-site analysis that looked at timing of pegfilgrastim among patients with breast cancer receiving dose-dense doxorubicin and cyclophosphamide. And then I also want to discuss the strengths and limitations of this study. So jumping right into the study, this was published in the Journal of Oncology Pharmacy Practice in 2022. It's entitled The Efficacy of Same-Day versus Next-Day Administration of Pegfilgrastim for the Prevention of Chemotherapy-Induced Febrile Neutropenia in Breast Cancer Patients Receiving Dose-Dense Doxorubicin and Cyclophosphamide. And as you can see, there are two names that are well known to the Cancer Care Institute, so very exciting to have two of our pharmacists as co-authors on this study. For background, breast cancer is the most common malignancy diagnosed among women in the United States, and treatment with dose-dense doxorubicin and cyclophosphamide, or dose-dense AC, is a standard regimen for human epidermal growth factor, receptor 2 or HER2 negative breast cancer. However, the dose-dense AC regimen is associated with a high risk for neutropenia and febrile neutropenia, so there is a recommendation for prophylactic administration of granulocyte colony stimulating factor, or GCSF support, with each cycle of dose-dense AC. So pegfilgrastim is utilized frequently because it is the pegylated formulation of filgrastim, so it allows for an extended duration of action, and so the patient only requires dosing once per cycle, so much more convenient than filgrastim. However, there is a theoretical risk that administration on the same day as chemotherapy of pegfilgrastim may theoretically worsen neutropenia due to chemotherapy's effect on the rapidly dividing myeloid stem cells. So for that reason, pegfilgrastim is generally not recommended to be administered within 24 hours after chemotherapy or 14 days prior to the next chemotherapy administration. We do have the option of using the on-body auto-injector for pegfilgrastim, which is the Neulasta Onpro, which of course this is a much more convenient option for patients because they have this placed the day of their chemotherapy. They don't have to come back into the clinic for their pegfilgrastim administration. There is a risk for device failure, and those rates range from 1.7 to 6.9%. There's also some important patient counseling, so patients should avoid any direct water exposure to the device. And then there's also been issues with efficacy if, while the patient's sleeping, there's direct pressure that's applied to the injector. And then cost has been a significant consideration as well. And up until this past year in 2022, we did not have a biosimilar available for the Neulasta Onpro. Just wanted to point out as well the NCCN template for the dose-dense AC. So it is considered a high febrile neutropenia risk, so greater than 20% risk for febrile neutropenia. And then down at the bottom, looking at the myeloid growth factor therapy, for pegfilgrastim, they do say that same-day administration is not recommended. So for the primary objective in this study, they wanted to determine the impact of either same-day versus next-day administration of pegfilgrastim on rates of neutropenia and febrile neutropenia among patients receiving dose-dense AC. This was a retrospective multi-center cohort study that was conducted at 3 different regional cancer centers, again with breast cancer patients receiving dose-dense AC and pegfilgrastim. One cancer center utilized same-day pegfilgrastim administration, and 2 centers utilized next-day administration. And in the analysis of their patient demographics, they did not see any statistically significant differences, so they did allow for pooling of the data between the 3 centers. For inclusion criteria, they looked at adult patients with any stage breast cancer receiving 4 cycles of dose-dense AC with standard doxorubicin 60 milligrams per meter squared and cyclophosphamide 600 milligrams per meter squared with a cycle length of 14 days. They excluded patients that had received chemotherapy within 1 year prior to starting dose-dense AC, or who received less than 4 cycles of dose-dense AC unless there was discontinuation due to neutropenia. They also excluded patients who received pegfilgrastim 48 hours after or more after administration of chemotherapy, or who had labs drawn more than 48 hours prior to chemotherapy. They also excluded patients who received prophylactic antibiotics with initiation of dose-dense AC. The primary endpoint was looking at incidence of febrile neutropenia, looking at same-day versus next-day pegfilgrastim administration. And then for their secondary endpoints, they looked at a variety of endpoints here with same-day versus next-day pegfilgrastim, looking at rates of grade 3 or 4 neutropenia, as well as rates of hospitalization and acute care visits due to complications from neutropenia, also need for chemotherapy dose reduction or dose delay, and then need for antibiotic treatment for chemotherapy-induced neutropenia. And they also analyzed device failure rates with use of the on-body injector for pegfilgrastim, the Neulasta Onpro. For safety endpoints for their definitions of febrile neutropenia, this included an ANC less than or equal to 1,000 and a temperature of greater than or equal to 100.4 Fahrenheit, or a diagnosis of neutropenic fever on the patient's chart review. And then they used the National Cancer Institute common terminology criteria for grade 3 or 4 neutropenia. So grade 3 ANC less than 1,000 to 500, grade 4 ANC less than 500. For their statistical tests for basic demographics, they used the t-test for comparison of age and body mass index and baseline ANC. The chi-square test was used for characteristics as well as their events and outcomes of interest in each group. And then they recorded their study events over all 4 chemotherapy cycles. They did specifically look at neutropenic effects on cycle 1 as well as during all 4 cycles. And then a p-value of less than 0.05 was considered significant. In terms of their demographic characteristics, as you can see from the p-values, there was no significant differences between groups. I did want to point out there was a slight difference in the performance status between groups. So we did see almost all patients in the same-day site had an ECOG of 0, 99.3%. In comparison, in the next day sites, there was a greater distribution between that ECOG of 0 and 1. So 79% were in ECOG of 0 and 18.2% were in ECOG of 1 at the next day sites. But again, no significant differences between groups, so the demographics and outcomes were pooled between all 3 centers. And then looking at the study enrollment, so there were 440 charts that were reviewed, and then looking at 1 same-day site, total of 146 patients after exclusions were included in the same-day pegfilgrastim administration, and then 2 sites were the next day pegfilgrastim. So after exclusion, that included a total of 214 patients for the next day administration. For the results here with safety data, this trial did actually find that same-day pegfilgrastim administration was associated with a significantly higher risk for grade 3 and 4 neutropenia. So that was a 24.8% difference between groups, as well as a significantly increased risk for febrile neutropenia with same-day pegfilgrastim, so a 13% between group difference. So significant findings there. And then in terms of other secondary outcomes, they did also show that same-day pegfilgrastim was associated with a significantly increased risk for acute care visits, so that was an 8.8% difference between groups, and also antibiotic use for treatment of neutropenic complications, so a 14.1% difference between groups. In terms of rates of hospitalization, there was a trend towards higher rate of hospitalization with same-day pegfilgrastim administration, but that was not statistically significant. And then they also saw a trend towards higher rates of chemotherapy delays with same-day pegfilgrastim, and that was a delay of a day or more, but again, not statistically significant. In terms of chemotherapy dose reductions, they did see that same-day pegfilgrastim administration was associated with a significantly higher need for chemotherapy dose reductions, so a 15.1% difference between groups. And then they did see for the on-body autoinjector, they did see a failure rate of 5.2% per patient, so total of 8 patients experienced device failure. And that again aligns with the findings of previous literature suggesting a failure rate of 1.7 to 6.9%. So in total, the on-body injector was administered with 595 chemotherapy cycles, so that's a rate of 1.3% failure rate per cycle. And then looking at all of the outcomes in table form, you can see many significant findings here. So again, really the only non-significant findings were the need for hospitalization and the need for chemotherapy dose delay by greater than or equal to 1 day, but all other outcomes were considered statistically significant. So in this study, they did show that same-day pegfilgrastim was associated with a statistically significant increased risk for complications for patients receiving dose-dense AC. So this included grade 3 and 4 neutropenia, febrile neutropenia, acute care visits, need for chemotherapy dose reduction, and antibiotic use. They did see a trend towards higher rates of hospitalization and need for chemotherapy delays between groups, but this was not statistically significant. Also wanted to point out that there are some nuances in terms of the studies that have been conducted looking at same-day versus next-day administration. And I do have a table that was included in this study just looking at a variety of chemotherapy regimens and the outcomes in terms of same-day versus next-day administration. But it is challenging because some of the studies have included intermediate risk regimens, so that's a 10 to 20% risk for febrile neutropenia in comparison to high-risk regimens such as dose-dense AC with a greater than 20% risk. So challenging in terms of making sure we're comparing apples to apples. And then also during the COVID-19 pandemic, the NCCN guidelines expanded their recommendation for use of GCSF, so that did include regimens with an intermediate risk for febrile neutropenia, so potentially may be skewing some of the outcomes as well. So as I mentioned, this is just a summary of some of the current existing literature with a variety of chemotherapy regimens and showing support for either same-day or next-day administration. So this is a table of the studies that have favored next-day administration of pegfilgrastim. So again, we see breast cancer and AC being included in this, showing a rate of febrile neutropenia of 2.5% versus 1.9% with next-day administration. And then any grade neutropenia, 26.7 versus 10.5%. So significant findings for breast cancer. But then, as you can see, we do have a variety of other regimens, including RCHOP regimens that are included here as well. And then looking at studies that have favored same-day administration, again, we see a variety of studies included here. So again, we see RCHOP and other regimens such as FOLFOX or FOLFIRI. And again, I just wanted to point out that it is challenging when we're not comparing high-risk regimens to high-risk regimens. So again, the dose-dense AC is considered a high-risk regimen greater than or equal to 20% risk for febrile neutropenia. And then in comparison, looking at our intermediate risks, so our CHOP regimens do fall into that intermediate risk category with the 10 to 20% risk for febrile neutropenia. So for strengths with this study, certainly provided real-world data looking at 3 different regional cancer centers and had strict inclusion and exclusion criteria to really limit bias. Also, we're able to include a patient population with similar demographics, again, a lot of rural communities surrounding these 3 cancer centers, and then generally similar processes for identifying febrile neutropenia and lab monitoring between the centers, and this included the availability of a triage call center at all centers. Some of the limitations of the study, so, of course, it is a retrospective review, and these healthcare systems were non-affiliated, so there may be some, differences there. And then also, as a retrospective review, there is certainly risk for selection bias and discrepancies during data collection. And then also, just in general, the standard documentation for neutropenia and potentially looking at that retrospective review. If the patient did require chemotherapy dose reduction, likely that documentation was more detailed and explicit in comparison to patients that maybe also had neutropenia but did not require chemotherapy dose reduction. So potential limitation there. So in conclusion, this study did find that same-day pegfilgrastim administration did lead to clinically and statistically significant increases in neutropenic complications. So based on the findings of this retrospective study, the recommendation is to provide pegfilgrastim as a next-day administration for patients with breast cancer receiving Dostans AC. And here are my references. And thank you so much for listening to my clinical pearl.